to introduce Dr. Laurence Roope, who is a senior researcher at the Health Economics Research Centre in Nuffield in the UK, in the University of Oxford. He has worked with the United Nations and the World Economic Forum and the WHO in the past, and he's going to talk to us today about the Candor study. Thank you, Larry.
Okay, great. I think we're here. Great. Can everyone see this okay?
Yes.
Excellent. Okay, look, thanks a lot. It's a pleasure to be here. Thank you so much for the invitation. So today I'm going to talk about evidence from the Candor study, which is a study which was designed to assess global public opinion on a whole variety of COVID-19 related policy issues, including vaccine allocation, attitudes towards donations of COVID vaccines, COVID mandates, and more generally, pandemic preparedness. So just a brief bit of word about the sort of background to the study. So this is a study which was initially conceived last year, towards the end of the year. And in fact, it was almost exactly this time last year that we went into the field. And it was originally designed really largely to look at the issue which was going to become a big topical issue very shortly, about the allocation of scarce vaccines. So if we think back to 1 year ago, we knew that we had some effective COVID-19 vaccines, but we did not yet have access to any of them other than high-income countries. We were anticipating that we would shortly have some access to vaccines, albeit that they'd be pretty constrained. So this was the sort of background, and it was set up by my colleagues in Oxford, Professor Philip Clark, the director of HERC, where I'm based, and Professor Ray Dutch, a political scientist at Nuffield College and the director of an experimental sciences lab in Oxford. So this study has now turned into a longitudinal study. In fact, the second wave is just about to go out now, 1 year later, but I'm going to be reporting today on various findings from the first wave, which was an online survey of about 15,500 adults across 13 countries: Australia, Brazil, Canada, Chile, China, Colombia, France, India, Italy, Russia, Spain, Uganda, the US, and the UK. Okay, so briefly, we collected public views on a range of COVID and related issues. As I said, how to prioritize scarce vaccine doses, the issue of donating vaccine doses from high-income countries to lower-income countries, whether private purchase of vaccines should be allowed, whether vaccination should be mandatory, and then also somewhat broader issues such as how I felt that government spending on medical research should be in the future compared to before the pandemic. And on the sort of flip side of that coin, willingness to pay taxes to build resilience to future pandemics. And I should also say that sort of beyond what I'm presenting today, the Candor really is a very rich data set. So we collected a very, very wide range of not just socio-demographic variables, not just the kind of usual suspects that would typically be employed in a lot of economics and health economic studies, but also notably political views, the sort of political identity that people feel, their willingness to take risks and so on. And you'll see shortly how we use some of that information. A quick word about the sampling strategy. So it was an internet-based survey of adults. We used quota sampling to ensure that the samples broadly matched national populations on gender, age, education, and also economic region. And the result, we also did post-stratification weighting to try, where there were remaining imbalances. I'd say certainly in the high-income countries, they're really quite representative, somewhat less so in some of the lower-income countries due to some of the inherent difficulties in getting, really quite poor people in lower-income settings involved in online studies. In many countries, comparisons with the comparative study of election system, or in the US particularly, but also in several other countries, suggested that really they broadly represented political opinion in most countries, which was a sort of an additional reality check in a way on the representativeness of the data. So who should get priority for a COVID vaccine? The first kind of research question that we had. Well, given limited initial supplies, all governments really had to make difficult choices over whom to prioritize to receive first doses. And indeed, we are now, I suppose, going into a situation where potentially we've got similar choices over booster vaccines in many high-income countries. So which groups should be prioritized? Well, of course, it might be older people, people with health conditions, people that are vulnerable, because of their age or comorbidities. But it could be health workers because, of course, they are on the front line. They're essential to keeping the health service going and to tackling COVID. They're also very much exposed to the virus. What about teachers? There's a lot of discussion about teachers in some countries. The evidence suggests they're not particularly at higher risk than the general population, but they play a special role in schools by keeping education going safely and in turn allowing parents to continue working and so on in a way that is difficult when they're homeschooling. And then what about something like public transport workers, let's say taxi drivers, for example? So there was evidence, for example, in the first wave in London, especially, that taxi drivers were really at quite high risk. And this is, probably a combination of the sort of environment that they worked in, sort of closed spaces with poor air circulating around, but also due to the socioeconomic context that a lot of taxi drivers are based in. So when we look at it across these, I mean, even thinking of a few, potential candidate recipients of vaccines, we can straight away see that it's not a standard health economic problem. And this is really because the pandemic itself, but also the related lockdowns and social distancing, mean that the impact of the prioritization decisions that governments make really have very far-reaching impacts that go well beyond the health sector. And perhaps not surprisingly for those reasons, and there are certain value judgments that potentially come into these decisions, that policies did vary to some extent across country. So just at the time that we were going into the field last year, around in early December last year, we did a kind of a review for the countries in our sample. We did a review of what kind of policies they were planning. And at that time, there was subsequently some divergence, but at that plan, this is a summary of the criteria that they had either proposed or used to prioritize vaccine allocation. So as you can see, there are certain criteria that really were universal. So health and social care, basically frontline health workers and other health workers really across the board were right at the top or very close to the top of priority lists. Age and vulnerability were also extremely highly used. And that's in no way surprising because people who had severe comorbidities and people who were older were at just such higher risk of contracting and having severe symptoms and dying from COVID. However, some countries, but not all countries, used a number of other criteria as well. So, for example, under essential infrastructure, we're thinking of things like police, firefighters, and even people who work in energy supplies and so on. And some certain governmental officials as well, sort of essential infrastructure for keeping the country going, if you like. In a number of countries had them quite far up the list. And in some countries had slightly more explicit policies, although we did not know at that time to what extent vaccines would reduce transmission of the virus. A number of countries did have references to using the allocation to try and actually reduce transmission. And just a couple of countries in our list, in Brazil and Chile, there was an explicit reference to trying to protect childcare workers in education and so on. So we felt that at the time, the question asked was, since there are potentially a number of value judgments involved in this, and because of the far-reaching impact of COVID vaccine allocation programs on wider society and wider economy and so on, what actually would the general public prioritize? So we asked 15,500 people across 13 countries, and then additionally we added Russia shortly after to bring it up to 14 to provide evidence on public views. So to do this, we used a discrete choice experiment, a DCE. A DCE is a quantitative technique for eliciting preferences, and it does this by asking respondents their preferred choice. So the choice in this case would be which sort of person to vaccinate, where people were described by a number of characteristics. So these are hypothetical choice questions. I'll show you one in just a moment, where each alternative is described as several attributes. And the idea is that by asking people a repeated number of questions and asking lots of people these questions, that we're able to elicit from that data the relative importance of those different characteristics in decision making. So for example, here's a choice question. So this would be one of a series of questions that a respondent in the survey would get. So as you can see, each of these persons, person A and B, differs according to several different characteristics. The vaccine could be given to one of these persons immediately. Please indicate the person you think should get the vaccine. So person A, for example, differs from person B in that their risk of a COVID-19 related death is much higher, 5 times as high, in fact. However, they're at similar risk of catching and transmitting the virus. They're at a similar income level. They differ by occupation status. So person A is a key worker involved in education and childcare, whereas person B is not only a non-key worker, but they also differ according to age. Person A is younger than person B. So the idea is that a series of questions such as these would be asked, but where the different levels of these attributes would differ in each case. So for example, in the next question, person A might still be younger than person B, but they might have a lower risk of COVID-related death than person B, and so on. So what are the key results? Well, really, I suppose we found that quite a range of these criteria were prioritized. And some of it was very much in line with perhaps what we might expect in terms of the most popular policies that have been adopted, and some was less so. So for example, certainly a very high weight was given to key workers who worked in health and social care. They were, right up there towards the top of the list, as were people who were very vulnerable. To some extent also, people who were older were prioritized, and again, that was a consistent finding. But where perhaps there was some divergence was that there were some attitudes towards income levels. So although there's been a lot of talk about inequalities during the pandemic, it was pretty much no countries, I think, really explicitly tried to prioritize more disadvantaged people generally, not considering clinical vulnerabilities, but more socioeconomic disadvantages. But there was some preferences amongst our sample towards prioritizing for less well-off people. There were also a range of occupationals that were considered as higher priority than others, and really, fairly high priority. Education and childcare was one of them, as was police and firefighting, water and electricity, some of those things that we might consider as essential infrastructure. What I think was really striking about our results is, I just showed you there the overall results. If we disaggregate those results by country and by continent, I'll show here kind of by continent or groups of continents to make it kind of tractable. But the interesting thing was that the preferences were remarkably similar everywhere, really, almost everywhere. So it's difficult, of course, to see on this slide all of the detail, but you can perhaps see even just by the shape of the slides. This is Asia and Africa combined. The shape of the which attributes get the most or have the highest margin of respects is really very similar across the board. So Asia and Africa looks very similar to Europe, which looks pretty similar to North America, which looks pretty similar to South America. Really remarkable consistency by region, and perhaps equally remarkably, a lot of consistency really according to disaggregating the sample in other ways. So if we disaggregate the sample according to age group, for example, you might think that, for example, that it would be that not all age groups would prioritize the elderly, but happily that's not the case. There was really very little difference there. And similarly to people of different age groups broadly had similar preferences about which occupation should be prioritized and other factors. Subjects' income, when we disaggregate it by income, there was basically pretty much no difference at all between high and low income people in terms of their preferences. And maybe most remarkably of all, even when we disaggregate it by political ideology, so the extent to which people identify with the left versus the right, there was very little divergence. There was a little bit of divergence on certain things, and not surprisingly, for example, those on the right gave less priority to poorer people than those on the left. But broadly speaking, there wasn't actually too much difference. Okay, let's move on to the next one. At the moment, there's a question, I guess, of boosters in high-income countries versus first shots in low-income countries, where sadly vaccine coverage is still so very, very low. In this graph on the right, we can see the share of people who had received at least one dose of a COVID vaccine a year ago, or in fact at the end of last year. And of course, there was almost no one anywhere. By April by early April of this year, we were getting up to fairly high coverage in a couple of countries around the world, in the UK, the US, for example. And then by July, lots of high-income countries as these shades turn greener and darker green, indicating high coverage. And until about a month and a half ago, we could see very dark green colors over, I suppose, most of the high-income world. In contrast, if we look at Africa, it particularly stands out as a massive region where there remains extremely low coverage. So though COVAX, for example, has been involved with trying to ensure global access to vaccines and equal access to vaccines, in reality, it remains extremely unequal. And indeed, governments have often acted in their own interest to protect their own supplies in a way which is detrimental to others by having massive stockpiles while others don't have anything. So we were curious about the preferences of the general public on this issue, particularly the preferences in high-income countries. So we asked people, but first of all, we gave 3 different possible principles for the allocation of vaccines. And the respondents had to express their agreement or disagreement on a scale of 0 to 100, where 0 was totally disagree, very much disagree, to 100 being very much agree. The first principle was that COVID-19 treatments and vaccines should be provided first for those in the world who need them most. Second principle was that COVID treatments and vaccines should be provided first for those around the world who cannot afford to buy them. And the third one really more tapped into vaccine nationalism, if you like, that COVID-19 treatments and vaccines should be first provided for those who live in the country in which they are developed. So these results, which we published in a short article in Nature Medicine, summarize the results. In terms of the principles, in all the high-income countries, the highest ranking principle, the principle that received highest agreement in each country, was that vaccines should be prioritized for those who need them most. This was followed by those who cannot afford them, and which was followed behind that in terms that the country of development should be a prioritization method. So I suppose quite progressive attitudes, you could say. Moreover, we also asked people a more direct question about whether they supported donating some vaccine doses from their country's stockpiles. Between 48% and 56% across our sample of countries supported donating some COVID vaccines. And of those who did support donating, more than 70% favored donating 10% or more than 10% of their country's doses. This contrasted with only between 15% and 26% who explicitly said they were not willing to donate any doses. And then we had some don't knows and prefer not to say it as well. Perhaps even more encouragingly, in a follow-up article, which should be coming out in a few days' time in Applied Health Economics and Health Policy, we did a heterogeneity analysis where we looked at different subgroups in the data. And what we found was that really whenever we disaggregated by different education levels, by political ideologies, by income levels, and also several other factors, that the encouraging thing was that in every subgroup that we looked at, there was majority support for donation. And that held even down to political ideology. So on the left, it was true that as we anticipated, there was a stronger preference for donation on the political left, with 64% of people across countries supporting some level of donation versus only 11% who said do not donate. Even so, among those on the political right, 51% supported some level of donation, whilst only 32% said that they should not donate. So this is something I think that potentially provides a lot of political capital to high-income countries that are considering this policy. What about attitudes to private provision of COVID vaccines? Now, I think happily this isn't something that we've seen too much around the world, but we have seen it in a couple of countries. So India and Pakistan. India is one of the countries in our sample, are two countries in which there have been private markets, and which indeed have created a lot of controversy. Across all of our countries, in all the countries that we asked this question, there was really very strong support for COVID vaccine provision being entirely and exclusively through government channels. There were perhaps 15 to 20% of people who felt that it should be government and private. Now, the only caveat to that is that whenever we moved on to ask hypothetical questions about whether people would be prepared to go privately to buy a COVID vaccine, if indeed it would get them access more quickly, then there were, the picture was a little bit more nuanced with fairly sizable proportions in some countries, and in some countries majorities who said that they would do. But in terms of the actual policy, what people think the policy should be, they felt that it should be through only government channels. Now, another topic that's become very topical and really is controversial, and indeed has led to riots on the streets in several countries recently, relates to mandatory vaccination. So this is a question that we asked again this time last year, something that should be borne in mind about all this data, that it is a year ago, and that attitudes may well have changed, and we'll find out soon in a few weeks' time, actually, if they have done, from our new data. But even a year ago, before the vaccines had actually been launched, if you like, there were signs of significant polarization on the topic of mandates. So if we think back to the vaccine allocation slides, there was this remarkable consistency of preferences across countries. But when it comes to mandation, a lot of polarization. So the UK and the US, for example, you can see a large pool of people strongly disagreeing with the idea that government should mandate vaccines, and another pool where people strongly agree that they should do. Similar in the UK. In France is an example of a country where there was really strong disagreement with mandates, and interestingly, there are indeed, it is a country that has some mandates now. So I mean, it will be very interesting to see how some of these attitudes have changed in countries that have developed stricter mandates. Italy's another country which we'll be interested to see how views have gone as people have had some experience of mandation. Turning to the slightly more forward-looking questions. We asked respondents that going forward, compared to prior to the pandemic, should government spend more or less on medical research than previously? These results aren't surprising, given that medical research had just led to a couple of effective vaccines, being found in trials to be effective. But nevertheless, the numbers are pretty overwhelming. So these, the second darkest blue, so the large bars in the middle of the chart here express preferences for spending more on medical research than before the pandemic, with the dark blues on the left being to spend the same amount. So really almost everyone felt that we should be spending at least as much and often more than prior to the pandemic. What about the flip side of that coin, the willingness to pay taxes to fund pandemic prevention spreading, which of course medical research could be a substantial part of? Well, the willingness to pay some level of taxes ranged from about 25% in Brazil to 77% in India. Of those people who were willing to spend something, we used a double-bounded contingent valuation approach to elicit the willingness, the amount of taxes the amount of annual taxes that they would be willing to pay. There was really very large variability across countries in this, ranging from about $13 in Colombia to $816 in the US, and these are figures that are adjusted for purchasing power parity, so they really are quite big differences. If we think of a country like the UK, for example, and the size of what does this size of amount mean? Well, £563 amongst those who are willing to pay something. If we adjust that by the proportion who are willing to pay something and we scale it up by population size, it works out as being equating to roughly about 5% of the NHS's annual healthcare budget, or equivalently about 1 percentage point on an extra 1 percentage point on the lower band of income tax. So fairly sizable amounts of money, but kind of, I suppose, believable as well. They kind of have some sort of face validity, I guess. So just to wrap up, the first wave of the Cantor study captured very much a snapshot of views 1 year ago. There was a remarkable consensus across countries on certain issues regarding the pandemic, priority groups for COVID-19 vaccination, opposition to private provision of vaccines, and also broad support in the high-income countries to donate vaccines to low-income countries. There was also strong support for increased spending on medical research. However, in many countries, views on mandatory vaccination were extremely polarized. We think that these data are interesting and important to monitor going forward, really because, well, largely because I think they can give policymakers an indication not only of what the public think is the right thing to do, but also the likely political acceptability of policies that they may be planning to implement because they think they're the right thing to do, and therefore the communication challenges that might arise from that, especially among different subgroups. Hopefully, in my view, hopefully the broad-based support for vaccine donation may provide political capital to do what I think is the right thing, and in fact is very much even in the selfish interest of high-income countries, because there is substantial evidence that ensuring better global access to vaccines would not only save many lives, but it would also be in the interest economically, and also in terms of reducing the risks of new variants emerging and causing further problems for high-income countries. So let's see how the public's views of these issues evolve, and we're shortly going to track those. So as well as looking at, again, just to say a little bit about the next wave, as well as seeing how some of these issues have evolved in terms of public opinion, we're also bringing in some new modules. We're going to conduct a randomized experiment to test the likely impact of cash versus lottery incentives to increase vaccine uptake. We're assessing the levels of vaccine-related corruption in many countries. So, for example, taking bribes or giving bribes rather to jump the queue to get vaccinated earlier, or on the other side of the coin, actually faking vaccine passports because either you haven't managed to get a vaccine or you don't want to get a vaccine and you want to go to a restaurant or whatever, and similarly with test results. And we're also going to aim to assess whether vaccines have a protective effect on mental as well as physical health. Last but definitely not least, this has been a massive collaboration with many collaborators around the world. I'd like to particularly thank our funders and the whole Candor team, but especially my kind of core collaborators, Professor Philip Clark, Professor Ray Dutch, and Dr. Mara Violato. Thank you.
Thank you very much, Larry, for what was a very interesting talk. We just a couple of questions here. Have you any insights into on how the type of vaccine or the vaccine, as in the AstraZeneca vaccine versus the Moderna or the Pfizer vaccine, on how that influenced the choices of people to donate or not to donate?
That's a great question. It's unfortunately not something that we were able to explore. So at this time, everything had very much been framed about a hypothetical effective vaccine. News had come out that there were effective vaccines, but no, it wasn't. It was long before there was any discussion, for example, of particular side effects from particular vaccines and so on. So no, unfortunately not. But I agree that it would be very interesting.
And just when you look at attitudes towards making vaccine uptake mandatory, is it something that, I mean, one would imagine that as this goes on into year 2 and 3, that we would expect attitudes to harden towards that. But is it something that you've noticed in, say, autocratic governments versus in liberal societies? I see China and Brazil seem to favor mandation of vaccines, whereas France and more liberal democracies seem to oppose it. Any insights or opinions?
Yes, I think that's a good point. I think that there is at least a trend towards that. So certainly it's true that yes, in China, that very strong support, and in France, a very liberal country, very much opposition to it. I think there is some truth in that. Although having said that, the only slight caveat I would give to that is that I think it's also, you could also infer from our data that broadly speaking, the lower income countries are countries that tended to be more in support of donation. And that could possibly be, there could possibly be something in that generally as well.
And last question or point, I just wonder, with the lower income countries, do you foresee a kind of lower rate of vaccine uptake due to poor educational levels? Well, again, that's another good question. I'm not sure that that's clear, because I think let's see how that evolves. But I'm not sure that it's clear, because I think there is also well, firstly, because we didn't necessarily see lower levels of hesitancy towards vaccines in the first wave.
in our study in lower income countries. But I think also, and if you think maybe it has something in line with the higher attitudes to higher support for mandation in lower income countries, I think there possibly is a feeling of, less confidence that the healthcare system is going to be able to protect you in a lower income setting, and less confidence. Probably people may be thinking, really, this is their chance. They're not going to necessarily benefit from reduced transmission due to other people getting vaccinated, for example.
Great, and thank you again for presenting to us today.
Thanks very much indeed.